Actually, one of the authors of the paper that I'm presenting today might be here.
Oh, that's
Um,
great.
yeah, so I invited, and I think at least one of them will be here. Can I like say something like we have Dr. Troy that is here today, like to start with?
Of
Yeah,
course.
okay,
Yeah.
great.
Yeah. No, you're welcome to say whatever you'd like. No, that's great.
I'll just wait for a couple of more minutes. And is there? Hello, everyone. Can can I get this going? Um, can you all hear me okay? And find the screen?
Yep, looks good.
Okay, perfect. Um, First of all, thanks everyone for understanding that reschedule. And I hope everybody had enjoyed the time of the solar eclipse yesterday. But this would be my second favorite topic of this week, aside from solar eclipse, which is the fractional excretion of electrolytes in volume responsive and intrinsic AKI in dogs. I chose this article. It's been a little while since it's been published in 2018, but I think this is still one of those recent articles that describe the utility of these diagnostics, which I'm very interested in. Also, hope to receive any inputs or any other thoughts or how you all utilize this diagnostic in the clinic as well. Um, I'm not sure if she's here. I sent an invitation to the authors, corresponding author, Dr. Dundee. He mentioned that Dr. Roberta Troya might be able to join. So hopefully we can also get to hear from the expert authors who actually has done this work. And feel free to chime in if you cannot understand what I'm saying. I have some accent, so I'd love to make sure that I can convey what I mean to say on each slides. So just wanted to start off with just review a brief recap in what the fractional excretion of electrolyte is. It is looking at the ratio of the amount of substance excreted relative to what is filtered. So in other words, fractional excretion of electrolytes is equal to the clearance of the substance divided by GFR. And the clearance is calculated based on urine substances time flow divided by plasma concentration. And the GFR can be estimated based on the measurement of creatinine from urine flow over plasma creatinine. So when we put these equations all together, we get this fractional excretion of electrolyte equation, which can be calculated based on the urine substance concentration, plasma creatinine, over the urine creatinine times plasma substance concentration. So we can utilize this equation to calculate the amount of fractional excretion of sodium, and that might be helpful information for various settings, including an acute kidney injury. So for normal kidneys, as we all know that the sodium that is filtered from the glomerulus should be about 99% reabsorbed by the renal tubules in normal circumstances. So normally the fractional excretion of sodium will be less than 1%. Now with the patients that present with azotemia or concerns for an AKI, we can look at this and see if that might be able to help us to understand if the patient has prerenal component or not. Because in the prerenal status where the patient is volume responsive or volume depleted, which in this paper short abbreviated as VRAKI, the fractional excretion of sodium should be less than 1% because all the RAX activation, angiotensin II activation, and suppression of anti-atrial natriuretic peptides that will increase the sodium reabsorption at the tubules that leads to the decreased fractional excretion of sodium. Whereas with intrinsic AKI, where their tubules are not functional, they are not being able to reabsorb sodium as healthy kidney tubules, the fractional excretion of sodium will be above 1%. Often in human literatures with acute tubular necrosis or other intrinsic AKIs is stated as above 2 to 3%. Definitely, there are these confounders. I think we, in the training or in our practice, we hear about these things such as diuretics or certain diets the patient's been on, or especially for those patients that has been receiving IV fluids, vasopressors, or also depending on what etiologies has led to AKI or concurrent with patients' kidney disease will be a confounding factors or influence how we interpret the fractional excretion of sodium. So that is about the sodium part. We could also use the same equation to understand the fractional excretion of urea in patients with AKI. And the thought behind of looking at the urea instead of sodium in a setting of the AKI is because this patient, not surprisingly, might have received diuretics that impair the tubular absorption of sodium. And because the urea reabsorption is mostly occurring at the proximal tubule side, that's going to be less effective for those patients who receive furosemide like loop diuretics or diazides. So fractional excretion of urea has been suggested as an alternative index for assessing the tubular integrity of the patients instead of fractional excretion of sodium. And there are some different cutoffs that I found on the literatures. Most of them comes down to about 35 to 40%. So for those patients that are avidly reabsorbing water because they are pre-renal AKI, fractional excretion of urea would be less than 35% and or 40%. And there are those human studies that has been suggesting that fractional excretion of urea might be a superior diagnostics to the fractional excretion of sodium in differentiating pre-renal and intrinsic AKI in human. I think this is one of the great articles that my mentor suggested to read, and this is really a nice summary of the fractional excretion testings in domestic animals, in large animal, horse, small animal, dogs, and cats. And this is another thing that is often the reasons that we don't as much utilize this information in clinic, or at least me personally, because it is better and intuitively make more sense that if we look at the fractional excretion or testing over 24 hours time frame or even several days, and just like having a spot sample when the patients were triaged at ER, try to understand what's happened. So the timed sample or factor the time into this equation would be better way to assess or representation of the patient status over the spot samples. Not surprisingly, there are some inter-individual factors that changes as well, such as breed, gender, and age. For example, this paper mentioned like puppies, like beagle puppies, are known to have fractional excretion of sodium 2 to 3 times higher um, in the puppy stage. So certainly, if they got into grapes and raisins and get AKI, or they are pre-renal, fractional excretion of sodium may be less useful um, in that cases. Intra-individual factors, dietary intakes, the timings of diets, and when we sample those urine and plasma, uh, patients with metabolic alkalosis that has increased amount of bicarbonate excretion will also increase the sodium excretion to maintain electron neutrality. Patients with Addison's disease, more importantly, patients that already has underlying CKD, may make it more difficult for us to understand what the results of the fractional excretion is. And a couple of other things they mentioned about some papers looking at nephrotoxicity induced by gentamicin in dogs. Basically, the fractional excretion seems to be a less sensitive markers than certain enzymes, biomarkers that were assessed from the urine. So I think still some of these questions are still to be investigated in the future. And also they mentioned about these things like diuretics, IV fluid, sodium bicarbonate infusion, alpha-2 agonists, which all of those that we get used for these patients with kidney disease. So here is, these are the slides that I prepared before I jump into the introduction and the paper. Just wanted to pause here and see if anybody had any comments or questions. Okay, to move on. Okay. So for this paper, they did a pretty nice job overall, or great job. They started with talking about the AKI iris grading system that is graded based on the serum creatinine as well as urine output. And then they jump in to talk about the differentiation between the volume responsive AKI versus the intrinsic AKI, where the volume responsive AKI is defined as a transient reduction of renal function that can be reversed after short-term fluid administration. And in the iris AKI, it has been suggested to define as increase in urine production above 1 ml per kilo per hour over 6 hours, and or decrease in serum creatinine to baseline over 48 hours. And certainly, I think this is one of the discussions or some area that I would like to receive your inputs or thoughts, because the pre-renal and volume responsive doesn't seem to be equate each other. where some patients that are pre-renal but not necessarily needs more volume resuscitation, like patients with like cirrhosis or hepatorenal, cardiorenal patients that actually might need decongestion, but they still has pre-renal because of perfusion problems. But I think for the purpose of this paper, volume responsive AKI seems to be the best way to represent the utility of the fractional excretion of sodium and the other electrolytes. I will keep checking the messages, but I will look at the slides. So if you see any message that are interesting, just chime in and let me know. So they also did a pretty nice job in presenting why the volume responsive AKI is significance to our patients because in human papers, it's been found that volume responsive AKI or pre-renal is an independent risk factor for mortality. And there are those findings that has been presented in human articles that tells pre-renal AKI has been shown to change, cause clinical and also pathological findings that renal damages do occur, even those patients do respond to volume resuscitation. And they didn't mention that back then in 2018, when they published the study, there are studies lacking of this evidence in dogs. What I thought is also phenomenal of this team did is they published a subsequent article on JVIM the following year, where they look at the levels of urine NGAL in dogs with AKI. As you can see in this figure, I don't know if you can see the cursor here. They look at the levels of the urine NGAL and compared with healthy and AKI patients, definitely a big difference. But when they compared the levels of urine NGALs between the patients with intrinsic AKI and the volume responsive AKI, depends on how they assess the parameter, like normalized with the urine creatinine or not. There were some changes, but overall, it was obvious that patients with volume responsive AKI did have changes or elevated urine NGAL comparatively to the intrinsic AKI. So I thought it was pretty neat for them to identify something that was lacking when they are working on the project, and then they kind of followed along and put out another great work to show what needs to be done in vet medicine. So this is kind of the highlights of this paper. They mentioned about these criteria of fractional excretion of electrolytes and the urine for indicating patients with volume responsive AKI that can be differentiated from the patients with intrinsic AKI if these patients do have fractional excretion of sodium less than 1% and excretion of urea less than 35%. I think there was a typo in the manuscript where they might have stated above 40% as the criteria. I think what they meant is less than 35% or 40%. But I could be wrong, and if anybody have some different thoughts, let me know. So they also look at the urine creatinine to serum creatinine ratio. Here is because the tubules are avidly reabsorbing water, it leads to increased urine creatinine concentration. So in the patients with pre-renal, they reabsorb water from the tubules that increase urine creatinine concentration. The ratio would be higher in the patients with volume responsive AKI, which is about 40 to 35, depends on the literatures. And they highlighted two preceding articles that I think is also great articles to mention here. One of those was from Davis Group. They looked at patients with naturally occurring AKI and the changes or the trends of GFR, urine production, fractional clearance of electrolytes in dogs, where just to present some areas that are connected or relates to the article we present today. Fractional excretion of sodium was correlated with the estimated GFR, and also the Fe sodium was reduced over time as the patient starts to recover. So here you can see in the patients that are survival groups, um, their GFR start to increase. And also on the right side of the figure, that the fractional excretion of sodium decrease over time for those patients that do have renal recovery. So their kidneys are recovering, so they can now start to reabsorbing sodium more properly, and that was related with or associated with survival. What I think that was also something that I think that is interesting point of discussion, and that connects to this paper, is that um, they looked at the non-timed or the spot fractional excretion, and that seems to be suitably predicting the trends of the fractional excretion that was measured over 24 hours. So I think there's a lot of those papers in human that says that it's not, but there are also these papers specifically in dogs that have shown that it seems to correlate. So the objectives and hypothesis of this paper, objectives was to evaluate the performance of these variables focused on the fractional excretion, spot samples of electrolytes and urea in differentiation between volume responsive and intrinsic AKI, and to investigate the potential for predicting outcomes based on these parameters that are measured at hospital admission, and assess the prognostic power of the iris AKI grading system in dogs. The authors have hypothesized that the untimed or spot fractional excretion of electrolytes and urea could predict the occurrence of the volume responsive AKI from intrinsic AKI in dogs. And the AKI grade and urine chemistry were having prognostic indicators during AKI. Materials and the methods. Was a prospective observational case control study over 2 years. Including criteria were patients that are found to have AKI, and they were graded based on creatinine and urine output. Um, it was a pretty nice job. They did highlight all the things that could confound the findings, and really focused on what they were aiming to patients with AKI by excluding patients that has chronic kidney disease, acute onset of chronic, post-azotemic patients, patients that has received diuretics, or some hypertonic saline before admission to ICU. For all those included patients, they graded based on iris grading systems and classified as volume responsive versus intrinsic, and then divided them into the outcome as survival to discharge versus non-survivals. For those patients that survived to discharge, they also looked at the 14 days and a month survival. They collected all these tons of information, clinical and clinical pathological data. As far as the urine output, only after the fluid resuscitation was performed, which means for the data that are presented here from actually patients that also might have could have received intravenous fluids before this clinical pathological data was performed, and the fluid therapy that are instituted for at least 6 hours, and the urine output was used to classify volume responsive versus intrinsic following that iris AKI definition. Collected CBC chemistry, CRP, blood gas, all the information from urine, urinalysis, sediment findings, urine albumin to creatinine ratio, electrolytes. Um, Initially, I was a little bit confused because I'm ignorant or dumb in knowing what the uric acid is, except that it's just different than urea. They measure urine urea and the uric acid, and talking to the corresponding author, they actually wanted to look at both, and they actually in the process or completing that validation of the uric acid measurements to be used for some different settings than AKI. So they did measure both, and they used the urine urea to measure the fractional excretion of urea, not the uric acid, in my understanding, and the urine creatinine. Statistical analysis. This is a little bit more than my understanding of statistics in general, but I tried to understand as best as I could to present. First, they started to assess the normality, and then they compared all these clinical pathological parameters between the groups, and then ran logistic regression, Cox proportional regression analysis. Basically, they put structured univariate analysis and then multivariate models to evaluate what are the risk factors for the presence of intrinsic AKI compared to volume responsive AKI. And they also looked at what are the risk factors or the factors that um, are associated with outcome. And for those, the parameters, they wanted to look for the predictive or the diagnostic performance for differentiating prerenal and renal AKI. They looked at the receiver operating curves, which tells us the how predictive or performance this parameter that is assessed for looking at that outcome they set to find and the cutoffs or the variables for fractional excretion of electrolytes and this parameter for discriminating these two conditions, and also looking at the cutoffs that can predict the survivals from non-survivals. Just gonna pause here to see if there's any comments. Okay, they collected a total of 135 dogs, which had almost half and half, or 40%, 50% in prerenal and renal AKI. So I think that was a great thing they had for this study, especially they're looking at not only comparing between the groups, but also looking at the predictive diagnostic performance and having those pretty equal distribution was need for them to have. Not surprisingly, there were these unclassified AKIs that are excluded from analysis. And also these dogs had a fair distribution across each grading of AKI. There are these etiologies that were collected within volume responsive and intrinsic AKI, and we can come back to talk about this later. There are some conditions like patients that are septic, like diabetic ketoacidosis or heat stroke, which I think those would be the ones that might have potentially influenced the diagnostic performance of the fractional excretion they want to look at. And actually, they did mention about this a little bit in the discussion. So I think we can maybe, if you have some expert opinions, we can talk about this later on. Because a lot of these patients with volume responsive end up having a septic AKI or sepsis associated or sepsis caused AKI. As far as urine output, 10 of these dogs were anuric. So urine output was only available in 125 dogs, with most of these dogs' urine output was measured during indwelling catheter, some of that with voided collection. 35% of these dogs included had oligoanuria, which 37 of those, so majority of these patients that are oligoanuric had an intrinsic AKI. And 32 of these, so most of these dogs were attempted. They attempted to convert the oligonuria using diuretic therapy. And they did mention 10 dogs responded after furosemide, and the other dogs received mannitol, diltiazem, or both. And there's not details about how much the dogs have responded and how much urine output has changed, which I was just personally interested, but also that may not be within the scope of this paper. The survivals, 60% of them had survived, which I think that in lines with previous oldest papers in AKI in dogs. And all of them were alive in 14 and 30 days, which is great to know that all of that had a good long-term outcome. And there was a higher mortality in intrinsic AKI over volume responsive AKI, and not surprisingly, patients with oliguria and urea had worse mortality than non-oliguric patients. I wasn't completely sure, but it looks like, based on how they presented, doesn't look like any of the patient had underwent extracorporeal therapy, hemodialysis, or peritoneal dialysis, but it's not specified, or I might have missed. It's interesting that volume responsive AKI had a mortality nearly 20%. I wonder some of that also could have been because we know that volume responsive AKI does impact prognosis, negatively impact, but also knowing that some of these, or 30–40% of these so-called septic, that might have also influenced the mortality of this cohort. After all, these are now our results. It's pretty exciting to see all the numbers here. So I'm trying to highlight some things that would be of our interest today. There were a significant difference between these two groups in many of these parameters, USG, urine creatinine, UPC, all the fractional excretion of electrolytes, and the urine creatinine over serum creatinine. So of these letters, the ones that has B are the ones that was statistically significantly different between intrinsic and volume responsive AKI. And you can look at the volume, the fractional excretion of sodium has a difference, pretty remarkable difference, eyeballing the numbers, although there probably a little bit of overlap with the lowest range of the intrinsic AKI with the highest range of the volume responsive AKI, as well as all the other electrolytes, and then the urine creatinine above serum creatinine. What's interesting for me, and this is also one I think would be interesting to look in the future or look back for more previous papers in the past that might be helpful us understanding, is that the fractional excretion of urea was not significantly different between the groups. There might be a little bit of trend of lower fractional excretion of urea with the pre-renal or volume responsive AKI with 38.7%. The way they presented the numbers are based on the normality assessment. So this is presented as mean SD versus the other one is presented as, actually it's mean SD and median and range. So it's a little bit tough to know what's the apple to apple number, but definitely there was not a statistically significant difference between these two numbers. Moving on to the logistic regression, univariate and multivariate model that predict that AKI. These are included in the supporting information of that article. The hazard ratio, the higher hazard ratio, more likely have intrinsic AKI. So these were creatinine, fractional excretion of sodium, chloride, and other electrolytes. Certainly, the urine specific gravity, lower the specific gravity, probably there is more likelihood for intrinsic AKI. So the lower hazard ratio more likely have intrinsic AKI. I really try to have a best understanding to be able to present this figure. The best way that I could try is that they laid on all these, the previous hazard ratio and the 95% confidence interval in this one figure, trying to graphically compare each parameters with some things that I checked over here, like AKI risk grading, creatinine, FeNA, or fractional excretion of chloride and calcium seems to have a higher hazard ratio compared to other parameters. They also noted that after univariate analysis, multivariate only base access and AKI grading was retained in the multivariate model. Does anybody had better? Thanks, Gordon, for saying that there was no access on extracorporeal therapy for the patients that are included. Dr. Forbes, thanks for putting up the articles there. Anybody else can have help me better understand this regression analysis? It looks like the bottom line was that there are these parameters that seems to be more likely associated with predicting the intrinsic AKI. Okay. Then I think this is the highlight of our interest today, is that, so how are these fractional excretion of electrolytes performed in differentiating pre-renal or volume responsive and intrinsic AKI. And the way that we look at the, I know everybody here knows, but just to recap, the AUC under the curve, the higher or close to the 1, the better predictive performance. So anything that above 0.9 is probably very golden. I think these AUC above 0.8 is decently excellent as well. And some of these values have close to 0.9. So all of these electrolytes were actually an excellent marker for differentiating these two etiologies. Um, and in the discussion, they had a sentence to talk about the fact that the fractional excretion of sodium was not significantly different between volume responsive group and the control dogs. And they said in a way that is interesting finding or unexpected. And I was just personally curious what they meant by saying that, because with the control dogs, we know that fractional excretion of sodium is going to be less than 1%. That's what the healthy kidneys do. Volume responsive will have a less than 1%. Maybe what they meant is that volume responsive might even have a lower fractional of excretion of sodium compared to the control dogs. But it wasn't surprising to me to see that there was not a significant difference between the healthy patients and the volume responsive AKI. Coming back to this table, fractional excretion of sodium, 0.9% or above, were 83% and 75% sensitive and specific in predicting intrinsic AKI. And these were chosen based on the Udens index to balance up the best of sensitivity as well as specificity. So that was pretty lined in with the human articles. And this is one of the meta-analysis article that came out in 2022 that looked at the performance of these diagnostics for various settings. So they pulled into about, I think, 19 or 15 studies that, okay, so there are so many papers. Let's look at what's the overall diagnostic performance. The pool sensitivity of the fractional excretion of sodium was 90%, which was pretty good number to me, and then pretty highly specific. So the 1% seems to be the cutoffs, and definitely when they looked at these particular studies that evaluated this performance in patients with the CKD and the diuretics, not as great performance. Patients with receiving diuretics without CKD, still not a great performance. Patients that are oliguric and not having CKD and not receiving diuretics, excellent performance. So it still, I think that practically when we try to utilize this information, definitely these are the ones that could be confounding, but it seems to be that there is the narrow scope of the patients that this would definitely be helpful to have as a diagnostic tool. And one of the reasons, I guess, for personally that I've been wondering is that how much the impact of the IV fluids to the diagnostic or predictive performance of the fractional excretion in dogs. And they did noted this as a limitation, that patients that have received previous fluid therapy or ongoing fluid therapy was not considered as an exclusion criteria for this study outcome. And they mentioned like only a minority of dogs were included on intravenous fluids. The impact should be considered, which I think is a great statement to say. I think at the same time, on the other hand, the fact that they actually had included those patients that received IV fluids and having a great, excellent performance of the fractional excretion of sodium and other electrolytes, and having a similar cutoff in human studies, that might implies that at some degree the fluid therapy may not just completely screw that how we interpret these findings, and there could be still opportunity to use this information. And I try to look at other relevant information in those articles that they have also mentioned. And the Brown Davis group study, where I initially introduced as looking at changes in the GFR urine outputs and the fractional excretions. Actually, 3 out of these 10 dogs were included in the study did receive fluids from presentation to up to 2 days of hospitalization. So they did mention that patients with, fractional excretion of sodium was high in nurse survivals, but in survivals that it has decreased gradually over time, even in patients with polyuric dogs that receive a large amount of fluids. So it's not looking at the same thing as this article, because this was more of a prognostic and then longitudinal change over time in this patient's cohort. But I think that still implies that fluid maybe at some degree impact, but not as much for overall interpretation of these diagnostics. But this is where I wanted to pull question to the group here and see if there's some different ways that or some experience that you have that you find that whether this diagnostic is helpful or less helpful than expected in a clinical practice. Difficult to confidence is so yeah. Agree with all the comments. And there were some mentions about, or what if we compare USG and the fractional excretion of electrolytes? Does the fractional excretion of electrolytes provide a better predictive performance compared to USG? As you can see on these papers too, like USG was very significantly different. And I'm curious how you think about this, because at the end, these are 2 different diagnostics that look at different information and different, I guess, implication for diagnostic and treatments. Statistically comparing those 2 seems to be an interesting point of discussion.
In people, there is a concept of transient azotemia, where the kind of premise behind it is to stop trying to figure out whether it's actually pre-renal or intrinsic renal, because if the azotemia because transient azotemia would be defined as azotemia that resolves within 72 hours. And then those people, they had a better outcome than people who had more persistent azotemia. So to the point that some of these patients who have a 1007 or a dilute urine concentration, but their azotemia improves and their fractional excretion of sodium does seem to be correlated with that, I do wonder if it's telling us that there is a different type or a less severe renal damage going on there. I'm not willing to give up that differentiation, but to me, if I did a fractional excretion of sodium, then it sounds like it's giving prognostic information.
Yeah, makes sense. Thank you.
Jiwoong, nice presentation. Yep. Oh, hello. Can you hear me?
Yeah, yeah.
Perfect. Yeah, nice presentation. I don't think it changes what we do from a clinical perspective, because those that are going to resolve their azotemia, whether they have some intrinsic renal dysfunction to start with or not, those are going to have better prognosis overall. And so, I don't think it necessarily changes what we do. I think it confirms what the literature does say across the board between humans and dogs.
Yeah. The action-wise, maybe not going to change too much.
Are there many folks on here that are routinely running urinary electrolytes in these cases?
I run it occasionally. Kind of depends on the disease process, what their sodium is doing. I had a dog with a sodium of like 115, and I was curious, is it sodium wasting? Does it have is it just a hypotonic fluid resuscitation? What was going on with that dog? So kind of depends on the scenario.
Yeah, or like patients that are hyperkalemic, and we try to see if that is renal like patients' kidneys are doing its job to waste potassium or not. I think personally, when I try to use that in patients, most of the time they are on fluids or has resuscitated or on fluids, and if they're like heading towards the oliguric state, uh, sometimes I measure it and see if that will be any helpful information. Because I'm wondering like how much of urine output decreased because of intrinsic versus prerenal. But I think that's one that I think is hard time to understand um, the information that I gained from these measurements.
I do think that one thing that would have been nice to show in the urinalysis section in table 2 would have just been the urine sodium concentration as an absolute value rather than, or in addition to the fractional excretion.
Mm-hmm.
So we'll say that we're not always doing, fractional excretion percent measurements, and sometimes just getting a spot can even be helpful.
Yeah, good point. Just to finish up the slides, thanks for all the comments. And there was another paper from Dr. Segev that have shown the sodium excretion was correlated with GFR despite the IV fluid therapy. So we already talked about this a little bit. My question was, so what degree or the stage of the fluid resuscitation or rehydration or maintenance phase, how much of that impacts the diagnostic or prognostic power of this fractional excretion of electrolytes? And I think this just one of interesting or maybe academically interesting question that I have. And the fractional excretion of urea, as we talked about, less than 35% is suggested as cutoffs, and seems to be more specific or sensitive markers than sodium in the presence of diuretic therapy. In this paper, it was not significantly different, so there was no predictive performance at all. And the authors has mentioned about species-specific difference, like renal handling, dietary supply, and also interesting part of information is in this paper as well. Even they are looking at somewhat different information or implication. Fractional excretion of urea did not perform or having any difference between day 1 and day 7 in both outcome groups. So I just do wonder if there's any different reasons that this may truly not good prognostic or diagnostic information in dogs compared to human. Lastly, just looking at the numbers, the fractional excretion of calcium was better than any other electrolytes, which I thought was pretty interesting. I don't know if I know all the physiologists explained why. Because in previous papers, it's mostly focused on sodium, or sodium was found to be only predictive renal recovery. I found this article, or actually it's an abstract, that looked at the performance of fractional excretion of calcium that was associated with ATN, that was even for the patients that had underlying CKD or has received diuretics. Although they did not compare this over to other electrolytes from the urine. So I think that was something that could be an area of future study in dogs. This another review article has a really nice job for things that will affect the fractional excretion of sodium or urine sodium as an absolute value. Definitely, we see a lot of these things as well as human articles. Patients that has received IV fluids, patient that has liver failure, heart failure, even have received contrast. Sepsis is an avid sodium and water reabsorbers. CKD diuretics. So I think it is just good for my review and just to recap the limitations or confounders of these diagnostics. And there's another article that came out on JVIM last year that looked at the urine sodium concentration after furosemide in patients with heart failure to determine if the patients are responsive or not. And this group actually have shown that the patients that are responsive to furosemide with increased urine sodium did have a better outcome in survival and shorter time spending in oxygen cage. So there seems to be still more papers coming out looking at the value of the urine electrolyte measurements. And just to talking to this group of authors who they kindly has responded to my email because my curiosity was that if they still utilize this information in their practice, and Dr. Dondi mentioned that that still continues to perform well for the patients that are upon admission for suspected AKI dogs, or they also use for those patients that have contraction from diuretics in hospitalized patients. Also hypokalemia for differentiating renal versus non-renal origin. As you mentioned in the article, fluid therapy should be taken into account. And they have measured urea and uric acid, and now they're exploring the role of uric acid in some different settings other than AKI. And it's exciting to hear that this group will continue to explore this area and publish more studies. To conclude, I think we all at the end here to save nephrons, kidneys, and urinary tracts. Good physical exam history taking still perhaps would be the most important, and this information might be an adjunctive information. And some areas that I think would be interesting as a research in the future is the correlation between the timed and non-timed sample for fractional excretion in AKI patients as a marker of recovery, prognostications, and then comparing the sensitivity and specificities between the electrolytes of and the others biomarkers altogether, or also importantly, urine microscopy exam findings. The other groups actually did try to or attempt to score the urine microscope, but they couldn't have a consistent or having a good scorings to compare that to the fractional excretion of electrolytes. So I thought that was very neat thing they have tried it to put together all this information. That's all I have, and thanks for spending time. Is there any questions, other comments, thoughts?
Last thing that I was curious about would have been like length of hospitalization between the two groups. Not necessarily like looking at outcome data, but more just kind of time in hospital.
Yeah.
I think that that's one of the keys with, with trainees and teaching them, with intrinsic AKI, these are generally going to be in hospital a lot longer. That would have been nice to see in this paper too.
Mm-hmm. Mm. I just finished presenting and I just looked at this paper again, and they did say that one of the dogs received peritoneal dialysis. So to make sure that I don't lie. Yes, Gordon, I agree. And talking to these authors, they did a ton of information, and seems like there's been a collaboration between the editors and what the authors wanted to present, and kind of had to narrow down to the focus area. And I really do agree that the duration. I think then, unless anybody else have any comments, we can bring to close. And thank you so much. Have a great day.
Thanks.
Thank you. Really well done. Appreciate it.
Thanks.
Nice job.
Thank you. Did I hit stop